Hi, my name is Kate Sullivan, and I'm Marianne Anzabi, and we're going to talk to you about practical tips about newborn screening for severe combined immune deficiency. If you're thinking of starting newborn screening in your area, we have some tips that might help get you started. All right, so in the next slide, I'm going to show you what we hope to cover today. I'm going to talk primarily about newborn screening, what it is, what it isn't, and how to deal with it in terms of a diagnostic approach. And then Marianne is going to talk to you about practical aspects of delivering care to a patient who has a positive newborn screen. So the method is based on the TREC circle, which stands for T-cell receptor excision circle. It's a little piece of DNA that's generated at the time a T-cell is born. So if you have severe combined immune deficiency and you're not making T-cells, you won't have any TRECs. That's the basis for the test. It is off of a newborn screen heel stick, the same heel stick that's done for other newborn screens, but instead of using mass spectroscopy, it uses a PCR-based method, and that's why it takes a new technology when you introduce newborn screening for SCID as compared to the more traditional newborn screening. So one of the things to recognize is that every lab sets its own cutoff values. So your cutoff values, and in fact the way the results get reported out, may be different at your institution or your lab compared to other people. So let me explain a little bit about how this happens. So TREC circles are generated when T cells are born. The more TREC circles you have, the more T cells you have. The detection strategy uses PCR, which measures cycles. So there are two ways the results can get reported out. It can be a count of TREC circles. So in that circumstance, high is good, 0 is bad. 0 TREC circles means no T cells. The other way of reporting the results are cycle numbers. Here, a high cycle number is bad. It takes more rounds of PCRing to detect a signal. So in this circumstance, high numbers are bad, low numbers are good. So you need to be very careful to understand how your results are being reported out. So what's a typical result? So about 0.1% of the patients that you see, again, the number will vary slightly according to what your cutoff is, but about 0.1%, at least in the United States, are abnormal TREC results. Most of these are due to prematurity. And so our practice is to repeat the testing monthly until the baby reaches term. There are still some premature infants who continue to have low TREC numbers even after they've reached term, and I'll talk more about that in a minute. Overall, of all of the babies that are tested, only about 1 in 10,000 will require flow cytometry. So most of the premature infants that have a low TREC number, they will normalize over time. Of those that require flow cytometry, this is the breakdown of the categories of diagnosis. Congenital syndromes is the most common, secondary lymphopenia, prematurity that just needs a little bit more time to resolve. 9% of the patients in the United States turn out to have severe combined immune deficiency or SCID. You can see it's not the most common diagnosis, and this is important to understand in terms of developing your workflow. About 3% have idiopathic T-cell lymphopenia. We don't think it's SCID. We don't know what it is. And I wanted to highlight the last category because you need to give yourself permission that you don't always get a diagnosis within the first couple of months. It does take some time. In some cases, you're waiting to see if the T cells improve over time. In some cases, you don't have a genetic diagnosis. So it's important to recognize that you won't always get a diagnosis within the first few months. So what are the syndromes? So 22q deletion or DeGeorge syndrome is by far the most common, with trisomy 21, ataxia, telangiectasia, and miscellaneous other syndromes appearing in that list. And remember, this is the most common final diagnosis in children with low TRECs. Secondary losses of T cells represent the second largest category. Cardiac anomalies, multiple congenital anomalies, third space losses, other reasons to lose T cells sort of collectively comprise the second largest category of diagnoses with low TRECs. And so when you get to flow cytometry, notice that this is very focused on identifying SCID. That's the whole goal of newborn screening. And so I want to highlight that it's important to ensure that the flow cytometry that you do includes markers for naive and memory cells. The point of this is that standard SCID is going to have no T cells. But if you don't do naive and memory, you could easily miss a baby with Omen syndrome where you have memory T cells that are not going to be fully functional. We would usually test for HIV and we would usually do mitogen proliferation, but really flow cytometry is the cornerstone of the next step to identify infants with severe combined immune deficiency, which again is the goal of the newborn screen. So when we think about our workflow, we want to tackle two big problems. We absolutely want to find the babies with severe combined immune deficiency because we're going to put them on the transplant path very quickly. But we also need to pay attention to those other infants with low T cells, and this workflow is designed to get at the etiology. So the first thing is a good birth history. Is there prematurity, intrauterine growth retardation? Were there any maternal medications that could have impacted the infant's T cell? Then we do a physical examination, and the focus here is to look for syndromes. And then we always think about losses. Is the albumin low? Do we have any reason to think there might be a GI loss, which is really the only way in which loss can be semi-silent. So our first flow is to just be a good pediatrician and to try and make sure we're not missing a syndrome or a secondary loss. The next phase, if you haven't gotten an answer at that point, the next phase is to just look at the statistics. Syndromes are still the most likely, and remember, chromosome 22 deletion or DeGeorge syndrome can be subtle. So I always try and force myself to rethink about that as a potential etiology. Trisomy 21 is usually more obvious, but you may see some of the features evolve over time. And then some babies outgrow their lymphopenia. We have a very poor understanding of why this is, but that's why I said you need to give yourself permission to take time, and you need to let the parents know that you may not have an answer for them in one visit. My cautions about this are that you shouldn't wait too long. You want to give the baby a chance to outgrow their T-cell lymphopenia, but you certainly don't want to miss an opportunity to transplant a healthy infant with SCID or a healthy infant with another type of T-cell defect where transplant is going to be curative. And then my last caution is just because you can't name it doesn't mean you can't transplant it. And I mean that if you don't have a gene, but you know it's SCID, you know there's no T-cells, don't wait for a gene. You don't need to have a genetic diagnosis in order to prepare the baby for transplant. And I've seen some centers that really want to have a mutation result before they refer for transplant. And really, getting the baby to transplant is the whole goal of newborn screening. So don't delay waiting for a genetic diagnosis. So I'm going to turn this over now to Marianne, who's going to give you some practical information about actually delivering care to infants with positive newborn screen.
Okay, so now I'm going to talk about the practical information, and I'm going to specifically talk about keeping the baby safe in the home, the hospital setting, and the outpatient clinic. So patient care at home. First and foremost, you want to assess the family setting. You want to make sure, you want to work with the family and make sure that they are able to provide adequate isolation for the infant at home to protect them from any illnesses. You really want to spend special attention if they have other children in the home that go to daycare or school or community activities that could bring different infections into the home. If a family cannot adequately take care, protect the family at home, you might have to think about other options, such as putting the baby inpatient. Families should identify primary caretakers to limit the exposures. I would recommend to a family pretty much have the baby taken care of by mom and dad, maybe a grandparent, but not to have too many people involved in their care, because the more people involved, the more exposures they could have. Make sure that everybody that is going to be caring for the baby knows about the diagnosis and provide really reliable information, either sites that are on the internet or some education material, and we're going to give you some links at the end of this presentation. Frequently a baby is, after the initial appointment, they are prescribed prophylactic medications, and you want to make sure that the parent understands what the medications are, why they are given them, what the dose is, and how to administer them, and the importance of being compliant with that. And also, the family should know when and who to call. They should always have a reliable number to call somebody, and to be educated not to hesitate to call anybody. No question is too small. Educate them about the signs and symptoms of illness and infection, and advise them if the baby has come in contact with any family member or friend that has been exposed to an illness or has been sick, then to let their provider know right away. Next, maternal IgG and IgM CMV antibodies must be negative prior to breastfeeding. So initially, what we like to do when we find out that a baby has a positive newborn screen, we usually ask the mom to get tested immediately. We ask them to stop breastfeeding, pump, and then give them the lab order to go to the lab to test their CMV status. If it's negative, then they can resume breastfeeding at the physician's advice, or if it is positive, they will need to go to bottle feeding. If they are bottle feeding, they can use prepared formula, which is fine, but if they are reconstituting powder formula, it has to be done with sterile or boiled water. And all water that is used for the baby should be sterile. Even bathing water, you would want to boil it, have it cooled, and just to protect the babies from any pathogens that could be in the water. Again, you can't emphasize enough strict hand washing and use of hand sanitizers every time you touch the baby. That's really important for people to just really get to do it all the time. Have the families avoid daycares and any crowds. If the family does have to take them out, encourage them that they should keep the baby close to them. They should cover the baby when they're out. And again, they should not let the baby have any live viral vaccines, such as rotaviruses, MMR, and varicella. If the baby is inpatient in the hospital, it's important to have them in a positive pressure isolation room or an isolation room. It's really important to educate all staff on the unit about what SCID is, clinical and non-clinical staff, so they can adhere to the infection protection protocol. All staff in the hospital must always gown, glove, and mask and use protective isolation gear when entering the baby's room or being close to the baby. Again, you want to limit the number of staff members who care for the baby to limit the number of exposures. No sick visitors or staff ever, and all blood products must be CMV negative and eradicated. Again, no live rotavirus, varicella, or MMR. No live viruses vaccines at all. In the outpatient clinic, again, we like to educate all staff about SCID, and this includes everybody. This includes, the front door, registrar, the security. We want to let everybody know that this patient is special and that we all need to adhere to the strict infection prevention protocol. Appointments should be scheduled at non-busy office times, ideally in the morning or after regular clinic. We like to reserve a clean and sanitized room for the baby and family, and then direct the family to the reserved room immediately upon arrival. In the outpatient clinic, again, all staff treating the baby will use full protective gear, gown, gloves, and mask, and adhere to strict hand washing and hand sanitizing before each contact. It's nice to provide the family with a contact upon arrival and someone that can escort the patient through the facility to go to different areas such as a lab or to x-ray or anything else they might need to do when they're at the clinic, so that the infection control protocol can be adhered to. So some of the most common questions. We went over some of these, but the things that most commonly that our families call in or ask during the visit are things like, why does mom have to stop breastfeeding initially? And we briefly talked about that, but it's because of the risk of the CMV virus that a lot of people do have. It is dormant, but it can be secreted in breast milk, and it is really dangerous to a baby with a weakened immune system. And then we asked, the mom would say, well, what is CMV and how long does it take to get the blood results? CMV, I just talked about what the virus is, and it takes about a day to get the results. So you really want to encourage the mom to go to the lab and get her results tested, and then we'll take steps to whether or not she can resume breastfeeding. Why does the family and the baby have to be evaluated by a pediatric immunologist? A lot of times our families have never even heard of the word immunologist. So at first you want to explain that to them and just let them know that it's really important to be evaluated and treated by someone that has been trained in the immune system and can properly evaluate and diagnose your baby and follow them and educate you to get the best treatment for your child. And what are the precautions that the family may take? We already spoke about them, but basically you just want to keep the baby protected. The baby, they need to understand that a baby that has possibly has severe combined immune deficiency, has a very compromised or no immune system, and they really need to be protected from any kind of germs that they could be exposed to, because they could get very sick from them. And if the baby does have SCID, what is next? And that's also why it's so important to come to the immunologist, because they will be educated at the visit what the treatments are, such as a bone marrow transplant, and what the providers and the families can do to get the baby prepared for that. Some of the best resources that we find that are reliable and really helpful for families are the Immune Deficiency Foundation. Here is the link for that, and they have some wonderful pamphlets, one of which is Understanding Low T Cells, that really talks about what a newborn screen is, what a positive screen means, and what type of treatment to get for those results. There's also a video on there that is really great, that is done by a family who has had a baby that had SCID and had to protect the baby in their home, and it really gives a first-hand look at how difficult that can be, but how it can be done safely and how it can still be rewarding to be with your baby as the baby's developing and keeping them safe for the transplant. The next one is SCID's Angels for Life, and that's another great resource that has a lot of good information. It has a lot of family support there. That was started by a family that had a baby that they lost to SCID, their first child, but they had a second child in which they were able to get to transplant, and the child is a young adult and doing very well. So this family has dedicated themselves to really helping other families that have the same diagnosis. There's also some limited financial resources through SCID Angels to help a family with the financial burdens during this diagnosis. And lastly, we have the Jerry Modell Foundation, which is another great resource for information on SCID and severe combined immune deficiency and other immune deficiencies. Okay, so now we'd like to show you how we set up our room in the clinic. First, we will reserve a room that we have set aside for the family that's going to keep coming in with the newborn that has had a positive SCID screen. We're going to have previously sanitized it, and we require all staff entering the room to use full protective gear, such as a gown and mask. And in the room, we're going to wash our hands and put our gloves on. I'd like to introduce myself to the family and let them know that the reason that we are fully protected is not because that the baby is contagious and that we're afraid of them. We don't want to instill any fear, but simply because we're trying to do our best to keep them free from any germs that we could possibly bring in. So we're going to do good hand washing. And if you don't always have, every time before touching the baby, you want to be very conscientious of washing your hands. So we have soap and water is great, but also hand gel sanitizer is something also very good to do frequently when you're working with a baby that has an immune deficiency. And then we would have our room set up. It's pretty simple. We would have a scale for the baby that's been previously disinfected. And we would also have any material that we might need in the exam room, such as a stethoscope. And always have alcohol wipes available if there's any sanitizing that needs to be done for any equipment that you might use, or just anything that might need a wipe down for the baby. In the room, we'd also want to be prepared with our education material, and we like to hand out to the family the pamphlets from the Immune Deficiency Foundation. They have a number of really good pamphlets for families who have a baby that has a presumptive positive SCID or actually has the SCID diagnosis. The first pamphlet, which is their newest, is Understanding Low T Cells Results from Your Baby's Newborn Screening. And this is an excellent resource to explain what a newborn screening is, what a positive screen means, and what the next steps would be taking in diagnosing and treating the infant. They also have a brochure that comes in both English and Spanish. It's labeled Severe Combined Immune Deficiency, and it's a guide for parents following a diagnosis. Another really important pamphlet is talks about infants with severe combined immune deficiency should not have the live rotavirus vaccine. This is very important to really make sure our family understands this and let them make sure that their primary doctors or anybody that is taking care of their baby knows that the baby cannot get this vaccine. They do have a sheet that actually it's really great for even your primary doctors to have, and that basically explains what a newborn screen is. And again, like the first pamphlet, what the screen is, and if the screen is positive, what the next steps might be. And it kind of helps alleviate some of the anxiety of a positive newborn screen, that it's just a screen and it is not yet a diagnosis. And I'd like to share with you that they also have this fabulous handbook that actually has a chapter on SCID, but it also has many, many chapters on many different types of primary immune deficiencies. And it's an excellent resource for a provider, a student, and a family that to learn about immune deficiencies. All these are available on the IDF website. You can order them through the internet, or you can call the IDF directly and they will send them to you free of charge.